Yes. Shall I start?
Yeah, please go ahead. Yeah, Dipendra.
Hello, good morning and good afternoon. I'm Dr. Dipendra Bhusal from HIEM third batch. Today, I'll be presenting on delirium or acute confusion. I will be focusing on delirium introduction, causes, risk factor, precipitating factor, approach, mental state examinations, and investigations, management, summary, and lastly, reference. So let's start. Basically, delirium, sometimes also called as acute confusion, is a common clinical syndrome which is characterized by disturbed consciousness, cognitive function, or perception, which has an acute onset and fluctuating course. It usually develops over 1 to 2 days. Delirium is acute confusional state, which is common in hospital medicine. In elderly, prevalence of delirium ranges from 11 to 42%. And it is estimated that 1/3 of delirium cases are preventable. In addition, detection and documentation of delirium by emergency physician is poor, with reported sensitivity rates as low as 35%. So it is an essential skill for emergency physician to be able to identify, assess, and treat with effective strategy. So we should think delirium, since it is preventable and treatable, we should suspect it, spot it, and stop it. In this introduction part, mainly this DSM5 criteria focus for diagnosis, but I'm talking this DSM5 criteria in introduction so that everybody will have a clear idea what DSM5 criteria is. DSM5 criteria says a disturbance in attention, that is reduced ability to direct, focus, sustain, and shift attention, and disturbance in awareness, that is reduced orientation to the environment. This is the first point. There should be a disturbance in attention and awareness. And second point says that this disturbance in attention and awareness should develop over a short period of time, that is usually within hours or to few days. And it represents changes from the baseline attention and awareness, and it also tends to fluctuate in severity during the course of the day. This is the second point. And third point says that there should be also an additional disturbance in cognition, like memory deficit, disorientation, language, and visuospatial ability or perception. This is the third point of DSM5 criteria. Fourth point says that criteria A, which is disturbance in awareness and attention, and criteria C, which is disturbance in cognition, should not be explained by pre-existing medical condition or established or new evolving neurocognitive disorder, and do not occur in the context of a severely reduced level of arousal such as coma. So point A and C should not be explained by the pre-existing medical condition. And fifth point suggests that this deficit in attention, awareness, and cognition should have the evidence from history or physical examination or laboratory finding that this delirium is a direct physiological consequences of another medical condition, like or substance intoxication or withdrawal or exposure to a toxin, or is due to a multiple etiologies. So basically, this fifth point is suggesting that delirium should should have any cause or any medical condition that will give rise to the delirium. So these are the DSM5 criteria. Let's talk about the causes of acute confusion. These are the general causes of acute confusion. These are prescribed medication, drug of abuse, withdrawal, infection, metabolic causes like hypoxia, hypoglycemia, acidosis, hyponatremia, and cardiac causes, neurological causes, organ failures, endocrine causes like myxedema, thyrotoxicosis, diabetes. These are some causes of acute confusion. To remember this cause, I have a mnemonic. Let's remember, whenever we suspect a delirium, let's remember SMAST. So what is this SMAST? So S stands for substrate, like hyperglycemia, hypoglycemia, thiamine deficiency, and also S stands for sepsis. M stands for meningitis, like meningitis and other CNS infection, and also mental illness like functional psychosis can give rise to delirium. A stands for alcohol, S for seizures activity or postictal phase, and H for hyper and hyperthyroidism, hyperthermia, hypercarbia, and hypothyroidism, hypothermia, hypoxia, and hypotension. And E for electrolyte, hypernatremia, hyponatremia, hypercalcemia, and encephalopathies like hepatic encephalopathy, uremic encephalopathy, hypertensive encephalopathy, and other encephalopathies. And D stands for drugs. Drugs of any sort which patients is taking should be checked for any adverse effect of confusion or delirium. So this is the mnemonics. So whenever you see a delirious patient, always remember the mnemonic SMASH to go through the causes of the delirium. Yeah, anyone can get delirium if their illness is severe enough. Dementia, like dementia, old people, hearing or visual impairment can also give rise to the acute confusion. So what are the risk factors? So these are some risk factors listed in RKM learning. Old age, severe illness, dementia, physical frailty, admission with infection or dehydration, visual impairment, polypharmacy, like if a patient is taking regular medicines, which more than 5 regular medicines, like polypharmacy, and surgery, if the patient underwent neck of femur surgery. This is also a very common risk factor for developing delirium. Alcohol can give rise to delirium tremens, and renal impairment can also give rise to the delirium. So what are the precipitating factors? Any change in environment, immobility, and use of physical restraint, use of catheter, malnutrition, psychoactive medication, intercurrent illness, and dehydration are some of the precipitating factors for developing delirium. So there are 3 clinical subtypes of delirium. They are hyperactive, hypoactive, and mixed. Based on the person psychomotor activity, hypoactive have the features like decreased alertness and slow speech, lethargy, and apathy. And hyperactive have the features like heightened arousal, restlessness, and wandering. Sometimes hyperactive patient can be very aggressive, and which is difficult to manage in emergency department. There is also third subtypes, which is mixed. In this subtype, both hyperactive and hypoactive features are present and is very difficult to identify. As you can see in this figure, person with hypoactive is saying like I'm fine, like slow speech is, he has slow speech, which is suggestive of hypoactive features. And other hyperactive features. Hyperactive one is trying to remove cannula and looks very aggressive, like hyperactive soft type delirium. Yeah, it is essential to recognize hypoactive soft type of delirium. Mostly hypoactive delirium are missed in the emergency department, so you have to be careful whenever you are suspecting a patient is in a delirium. You have to also look for the hypoactive features, because it is quite hard to diagnose and spot the hypoactive features. These are some difference between delirium and dementia. I guess everyone knows this, but nice guideline for delirium suggests to treat for delirium first. Whenever if there is a difficulty distinguishing between diagnosis of either this is delirium or dementia, or is this delirium superimposed on dementia, if there is confusion, you should always treat the patient for delirium. These are some differences that you can see in the slide. Like delirium has the acute onset, and whereas dementia has insidious onset. In delirium, consciousness and orientation is clouded and patient is disoriented, whereas in dementia, consciousness and orientation is clear.
Yeah,
Attention
I think, Dipendra, sorry to interject. I think absolutely right. I mean, in the actual practice, dementia people are they don't look unwell, you know. So normal terminology you give is pleasantly confused, you know. But the delirious people, they are unwell. As we've seen, they've got you know, quite a serious underlying pathology, which is failing the brain, really, you know. So delirious people are unwell, you know. So that's must be a distinction made when we assess them. And the dementia people, they are not unwell. They are bright, so we call them pleasantly confused. Okay, yeah, please continue.
Yes, so thank you, sir. Yes, psychosis is common features in delirium, whereas dementia, psychosis is less common. Moving on, let's go to the approach, how to approach a delirious patient. Firstly, we have to perform thorough ABCD. We should find and fix if there is any problem in ABCDE. In emergency department, we should always look for the primary survey ABCD. You should clear the ABCD first. Then you go for the focus history from carers, GPs, and other who are close to the patient. As you can see in this picture, there is positive delirium screen, and some it's hypoactive subtype. Someone is saying, yeah, we should be conscious that delirium is also a medical emergency. So we should identify, try to prevent and treat this condition. On focused history, we should ask for the onset and course of the delirium, previous intellectual function, like ability to manage household, pay bills, compliance with the medication, and use of telephone should be taken, and full drug history should be taken, including non-prescribed drug and recent drug cessation, and alcohol history and functional status, like activities of daily living, and if there is hearing aids and glass aids, that should be mentioned in our history. Let's talk about the indicators of the delirium. In history, we should be aware of these indicators of the delirium. This slide is taken from the NICE guideline. So NICE guideline says indicators of delirium is the recent change in the behavior, cognitive function like worsened concentration, slow response, and confusion, perception fluctuation like visual or auditory hallucinations, and physical functions like function changes like reduced mobility, reduced movement, restlessness, agitation, changes in appetite, sleep disturbance should be looked out for. And social behavior like lack of cooperation with reasonable request and withdrawal or alteration in communication, mood, or attitude should be noted. And this slide is helpful to identify the delirium case. So as this type of symptoms are the indicators of the delirium. Moving on. According to the NICE guideline, for the diagnosis of the delirium, these are some tools used in our setting. And firstly, DSM5 criteria developed by the American Psychiatric Association should be used in diagnosis of delirium. I already presented about the DSM5 criteria. And there is also a short confusion assessment method, short CAM. This is useful for A&E in emergency department, and CAM, confusion assessment method, ICU is used for whoever is admitted in ICU. So this is the DSM5 criteria. There should be disturbance in attention and awareness, which should develop over short period of time. There should be additional disturbance in cognition, like perceiving, reasoning, learning, evaluating, and remembering. These are the 3 points. And 4th point says these 3 disturbances should not be explained by the pre-existing medical condition. And 5th point says this condition is a direct physiological consequences of the another medical condition. Delirium should be a direct physiological consequences of another medical condition. These are the 5 criteria.
I think, you're right, Dipendra, because, in emergency medicine, we are aware that, sometimes the psychiatry or the crisis team tell us that, can you please exclude any physical reason, and then we will come and assess the mental health status. I think that's what Dipendra is talking about. When they ask us to exclude any physical problem with the people who are confused or excited or whatever. So these are things to look for, as Dipendra has beautifully put in. Yeah. So if these 5 criteria are not there, which can take about what, a minute or 2, so then you can say that, safely that this patient doesn't have any medical conditions. Oh, well done, Dipendra. Yeah, excellent. Yeah.
This is another tool, CAM sort. In short, I'll say in short, what this CAM sort is trying to say is that you have to have A and B. If to say a patient is present in delirium, both A and B features should be present, and one of C and D should present. Like in A, acute onset and fluctuating course of changes in behavior from the baseline, and in B, that is inattention, we have to check the patient have the ability to give attention or not. One common test I use for inattention is asking the patient to count from 20 to 1, and we can look for for patient ability to maintain or shift in emotion on counting from 20 to 1. So this A and B should present, and one of C or D should present. Disorganized thinking is defined as the irrelevant conversation, unclear idea, and unpredictable switch from the object to object. And if this C or D, one of these features present with A and B, we can call it, we can call the patient is in the delirium state. This is also a useful tool for A&E. Another tool is CM ICU. It is useful for ICU patient. It uses Richmond agitation and sedation scale. So you can go through this, but it is not important for in our A&E point of view. It is important in ICU point of view. Moving on. This is another test for cognition to look for the cognitive impairment in a patient. You do a mini mental state examination test. If you go through this slide, it's very easy. You can give the number. How many answers can patient give to you, and count the total. And if it's between 24 to 30, we say no cognitive impairment. If it's between 18 to 23, we say mild cognitive impairment. And if it's between 0 to 70, it is called as severe cognitive impairment. So let's talk about the investigation. I want to remember my mnemonics smashed that look for the cause of the delirium. You think of the cause first, then go through the investigation. Whatever the cause is, you go in that line of investigation. So some common investigation we do at bedside is oxygen saturation, blood glucose, ECG, and urine dipstick, chest X-ray. Laboratory, you can do full blood count, urea and electrolyte, and glucose. So other investigation that can be done according to the cause are ABG, arterial blood gases analysis, liver function test, coagulation profile, thyroid function test, blood culture, drug level, B12, folate, autoimmune screening, D-dimer, which is only focused part of the DVT or pulmonary embolism workup, and CRP and ESR is also helpful according to the cause of the acute confusion.
Yeah,
we should do CT scan.
Yeah, sorry, Dipendra means that we should not be requesting, because some clinician we know, they request every investigation available on the land. So that's not the medicine really. Okay, the medicine is, that Dipendra is saying, you can divide investigation in different groups. For example, some general investigation in this situation, which we do on every patient: ECG, saturation, blood, and chest X-ray. But when the CT scan comes in, then we have to be selective. So then we have to ask a question: why we are going to a CT scan? Why we are going to an MRI scan? So when the specialist investigation pop in, then you have to be a bit more delineative. Then you have to be more cautious, and then you must ask this question: so why I need a CT scan? Now, initially, I know we are always learning. So initially, this question will be difficult to answer. But if you keep on asking this question repeatedly in every situation where we encounter delirious patients, so then after about 10 years, 5 years, 4 years, believe me, you will be very, very good in answering this question, and it will make you a better doctor. Please do ask question when you're in some special investigation. Now, that's why the help is available. If we don't know the answer to that question, then you can ask your colleague, your senior, or you go to have a bit of research done. That's how we learn. Okay, gentlemen. Yeah, thank you very much.
Thank you, sir. CT scan is indicated if there is any focal neurological sign, if there is a confusion after a head injury or fall, if there is any evidence of rest intracranial pressure, we should also think about doing the CT scan. And if you suspect meningitis, meningoencephalitis, we can also do a lumbar puncture. let's go to management of the delirium. So firstly, identification and treatment of the underlying cause is the main point in management. Drug therapy in management of delirium should be avoided if possible. So we have to use drug very cautiously. So this slide was taken from NICE guideline. So we also have to ensure effective communication and reorientation and provide reassurance for people diagnosed with the delirium. Yes, effective communication, orientation, reorientation, and providing reassurance is always beneficial in this kind of a patient, and consider involving family, friends, and carers to help with this kind of condition is also beneficial in management of the delirium. Yeah, we should, as I talked previously in the first point, we should always look for the underlying cause and treat the cause first. If it's infection, you treat with antibiotic and send blood culture. And if it's due to the drug, you should ask the patient about the drug taken and recently withdrawn drug, or any non-prescribed drug. And anticholinergic drug are particularly implicated in precipitating acute confusional state. We should ask about the alcohol. If alcohol abuse is present, withdrawal is suspected, delirium tremens is suspected, we should treat in that way. Also, we should remember parenteral thymine in alcohol abuse. If there is any biochemical abnormality like hyponatremia, normalization should be done cautiously. These are the management for the cause of the delirium. And for management of the delirium, there are several technique recommended by NICE guideline. So verbal de-escalation technique. Verbal de-escalation technique means using calm language along with other communication techniques to diffuse, redirect, and de-escalate a conflicting situation. That is a verbal de-escalation technique. And non-verbal de-escalation technique, usually you should appear calm and self-assured. Even you don't feel it, you should act self-assured and should maintain limited eye contact with the patient. Yeah, these are the non-verbal de-escalation technique. And we should consider giving short-term, usually 1 week or less, alloperidol if we are discharging the patient also. If short-term alloperidol, and if delirium does not resolve, we should again reevaluate for the underlying cause, and follow up and assess for possible dementia should be done. If needed in sedation, we need sedation in mostly in hyperactive subtype of delirium, where patient is very agitated, aggressive, and sedation may require to carry out the essential investigation or treatment, and to prevent the patient endangering themselves or others, and to relieve distress in a highly agitated or hallucinating patient. Sedation is required. So if sedation needed, initial medication of choice is haloperidol. We should start at a dose of 0.5 mg oral or IM with regular assessment. Titration of up to maximum 5 to 10 mg can be done, but remember to give as low dose as possible. So for delirium due to alcohol, this side effect of haloperidol is like it causes extrapyramidal symptoms, and it prolong our QT interval in ECG. So we should avoid in Parkinsonism and delirium tremens, and we should do the continuous ECG monitoring before prescribing this medication. So wherever haloperidol is contraindicated, like I talk in it gives rise to extrapyramidal symptoms, so it should not be used in Parkinsonism and delirium treatments, you should give lorazepam at an initial dose of 2 mg IV or IM with regular assessment and titration to its effect. So how can we prevent in-hospital delirium? To prevent the in-hospital delirium, these are some technique. So we should provide appropriate lighting for the time of the day and regular and repeated cues to improve personal orientation. You should talk to the patient or any carer or patient relatives should talk to. We should encourage them to talk to the patient to improve personal orientation. Use of clock in hospital to improve orientation. Hearing aids and spectacles in good working order, and communication with the relatives as to the cause and treatment measures for the delirium, as they can be very anxious for their patient, and encourage family to visit and bring in familiar objects that they love from home. These are some prevention technique. And we should avoid use of physical restraint unless absolutely indicated, and we should avoid to keep patient in constipating state, and catheter should be avoided wherever possible. Anticholinergic drugs should be avoided wherever possible. Unnecessary ward transfer should also be avoided to prevent the patient from delirium. So these are some pitfalls that are present in present day on during management of the delirium. So some pitfalls are to failure to consider diagnosis, particularly of hypoactive subtype. We should always look for the hypoactive delirium in a patient, and failure to routinely assess the mental state of the elderly patient in the AD. Always remember to assess the mental status of the patient above 65 years of age. Failure to obtain history from relative carers of our friend. This is particularly important when trying to distinguish between delirium and dementia. So failure to obtain a full drug history. So failure to appreciate that the injury or particular head injury and pain are important cause of acute confusion. Requesting insufficient or inappropriate investigations, like Dr. told earlier. So a full set of blood test, X-ray, CT scan is not needed in the initial management, but it may need to find the cause of the delirium. And failure to appreciate that environmental factor are vitally important in prevention and treatment of the delirium. Like environment, what's his environment, what's patient is living on, and sometimes you also need to think of safeguarding and this kind of thing whenever you suspect any environmental factor responsible for delirium. So yeah, thank you. That is all. These are my reference.
Thank you very much, Dipendra.
Thank
Can
you.
I make a couple of points? I think I don't know. I mean, one is that in the presentation, some sort of initial slide or something where there's for in this situation like a neurophysiology a little bit, so alertness, what we mean alertness, like in the brain stem, reticular activating, what they call RAS, reticular activating system, a little bit like that. And but the other main point is that the physical restraint. Now we should not be using physical restraint at all in these sort of patients, because I'm talking from experience from our department. Now, in our department, so I start, talking against the physical restraint quite a bit, many years now, 10, 11, 12 years. Now, physical restraint cause harm to the patient, to the staff, to the environment. And the other important thing is we need a lot of personnel to restrain these people physically, because they're normally young people, 17, 18, 20, and they're very strong. okay, in our set of group of patients is mostly the drugs involved. And the second group is, people are epileptic, traumatic brain injury. So these are people come with they're post-ictal, they have taken a lot of psychoactive drugs, stimulating drugs. And physical strain is, I mean, even now is pathetic, is it? Day before yesterday, no, yesterday, Olu was there in research. I mean, this guy has got, epilepsy. He was post-ictal. He was young, and he was not, resting, and the people were on him. And now the other thing is lorazepam. Lorazepam, I think, should be the first choice of drugs because we know the antidote against that. Okay, and these people, they are resistant to lorazepam somehow. So I would say we give lorazepam, okay, a couple of times, once and twice. But if still like that, please call the anesthetic because they need some sort of propofol to that level. And once they get propofol, they relax, and then you can arrange investigation, treat it. So that's the one point about that. And as I said, sedation point of view, use the drugs which you are familiar to and which you have a readily available antidote. Now, antidote can be chemical, like flumazenil in case of benzodiazepines, or it can be like basic life support. If the people have got a low respiratory rate or they're not breathing, then the clinician should be able to sustain that patient by the basic life support or even advanced life support. And, so haloperidol, I agree with you. Haloperidol is out of fashion. I won't use haloperidol because I will go with the lorazepam. And the second point is mixing drugs, like giving, because it happened actually. Okay, I came and I said, oh, give haloperidol. Dipendra came, he said, oh, give lorazepam. Then Dr. Boone came, he said, no. A couple of risperidone will work. So polypharmacy in this situation is always serious, always dangerous. So never do the polypharmacy. Okay. Examination point of view, you can't examine when people are in that state, but once they're relaxed, then please try to assess the conscious level. Brainstem function, very important, which is to just open the eye, look into the eye. Very simple, is it? And the other thing is very important point is there's a little bit, because this is interface between medicine and something else. Okay. Now, in advanced society, when people outside, people use science to abuse other people. Very important. For instance, they restrain. Okay. And restraining cause harm to people. We've seen this, lot of over the world, these sort of disturbances. So I think in third world countries, they don't use sophisticated means. They just shoot or something. These are hit with a stick. So that's again very important. So restraining is not looked favorably, should not be condoned by a medical profession. So we are educated people, we're a clinician, we love humanity, and we preserve life. Okay, please, restraining, don't go for restraining. Go for the, rapid tranquilization. And if that's not working, please involve the anesthetic, because the more you restrain people, the more they struggle, the more they get hypoxic, rhabdomyolysis, dehydration. And believe me, people have died, even in our department on that sort of stuff, So no, we preserve life. We don't harm the life. Okay, it's very important that we treat people appropriately. Okay, no physical strain, please. Okay. Thanks very much. So very, very, very good presentation. Any other question Guy can ask?
Can I just say, I really like how you justify all the things you're saying by reference to the source of the information. So that's very useful. And I like how you sort of organize your thought process, and it's reflected in the flow of your slides. You can only get better moving forward.
Thank you very much.
Our next speaker is Dr. Babu, who is joining us at 10 o'clock. And he'll be speaking to us about transient loss of consciousness. So I suppose we have, unless there's potentially, should we take a 10-minute break then? Because Dr. Babu is not logging in until 10 o'clock. He said he's got something else to do first, and then he's joining us at 10.
Okay,
Unless he's already here. Let me see whether
take
he's
a
actually...
break, is it?
Shall we take a break and come back at 10? Yeah,
that's fine. Thank you.
Okay, guys. See you at 10 o'clock.
Okay, sir.